In this presentation, we will talk about systolic intermotion of the mitral valve and liver transplantation, and we will look into the pulmonary artery waveform analysis for diagnosis. This patient was a 63-year-old male with a BMI of 30, and he presented with HCC-related liver cirrhosis and a past medical history of diabetes, hypertension, and headaches. He had a MELD score of 12, and his physical exam was unremarkable. His EKG showed a sinus rhythm, a first-degree AV block, a borderline prolonged QT interval, and the lack of R-wave progression in the anterior leads. He had a treadmill stress test, and his baseline heart rate went from 62 to 112, reaching 76% of the maximum predicted heart rate. And his baseline blood pressure went up from 126 systolic to 172 systolic. There was no evidence of ischemia, and his ejection fraction was 63%. For his pre-op cardiac testing, he had an echocardiography that showed thickened mitral valve leaflets, mild mitral regurgitation, and systolic intermotion of the mitral valve. There was a mild aortic stenosis, a gradient was 37 in his peak, and there was some discrete septal wall thickening with impingement on the left ventricle outflow tract. There was normal RV function with a TAPSE of 2.8 and normal systolic pulmonary pressure of 25. This patient had a repeat transthoracic echo done after 7 months, and we see some changes. On the mitral valve, we see there was an increase from mild mitral regurgitation into moderate mitral regurgitation. Also, the peak gradient increased from 9 to 14. Looking into the left ventricle, there's more hyperdynamic and significant dynamic LV outflow obstruction in the gradient of 54 that was not evident 6-7 months prior. Ejection fraction was a little bit higher by 10%, and now we have a elevated pulmonary artery pressure at 45 systolic compared to 25 7 months prior. 1 month after the last transthoracic echo, the patient underwent liver transplantation, and the dissection and the anapedic phase were uneventful. At the reperfusion phase, the blood pressure suddenly decreased to 70 systolic, and the PA pressure increased to almost 80 systolic. And there was some significant ST segment depression on the 2 and the V5 leads on the EKG on the monitor. Because of the significant hypotension, the blood pressure was supported with intermittent boluses of epinephrine, total of 40 mics over 10 minutes, and the dopamine infusion was started at 5 mics per kilogram per minute. So over the next 30 minutes, there's progressive ST depression, and the heart rate goes up to 110 per minute. There's severe hypotension in the setting of persistent elevated PA pressure, and a change in the appearance of the PA waveform. Here we see the PA catheter waveform tracing while the patient was hypotensive, and we can see there is a significant spike in one of the waves. And now the question is, what is this wave? Is it the systolic pressure, or is it the V wave of the PA catheter tracing? The S wave represents the systolic peak pressure during the ventricular systole in the pulmonary artery. The V wave represents the pressure increase in the left atrium during the ventricular systole. Essentially, it is showing the filling of the left atrium against the closed mitral valve, and the larger V wave indicates mitral regurgitation. The V wave occurs right at the peak of the T wave or just slightly afterwards, and the S wave, the systolic wave, occurs before the peak of the T wave, and that's how we distinguish between the systolic wave and the V wave, which is important for the diagnosis. So in this scenario, a intra-op TE is very helpful, and it showed that we had severe mitral regurgitation, which confirms the finding that we saw on the PA waveform. We had a working diagnosis of acute posterior medial papillary ischemia because we also saw ST segment depression. However, when we further investigated, it showed it was a simple systolic intermotion of the mitral valve without any wall motion abnormalities. This case also shows why it's important to have a PA catheter and the intra-T at the same time, because you can easily identify the V wave on the PA catheter waveform, but not clearly make a diagnosis without a TE. The TE is very helpful to make a diagnosis. On the other hand, it might be very difficult to have an immediate sign without having constant analysis of the pressure, which is not very practical in the real setting. This is a mid-esophageal aortic valve long axis view, and it's showing the left ventricle outflow tract. And we can see there's an obstruction caused by the mitral valve. And we can see this is the systole, and the mitral valve is open, causing significant regurgitation. This is the same view with the color flow Doppler, and we can see significant mitral regurgitation, and there's limited flow at the outflow tract and limited flow into the aorta. And we can see the heart rate is 102 beats per minute. This is the same view after the administration of Asmolol, and we can see the heart rate decreases 77, and there's significant flow now into the outflow tract, into the aorta, and less mitral regurgitation. So in this case, within 5 minutes of 30 milligrams of Asmolol, the heart rate decreased below 80, and the PA pressure normalized to 30/20. The blood pressure improved to 110/70, the ST depression normalized to baseline, and the remaining interrupt course was uneventful. There are many risk factors that can lead to SAM and ultimately to LVOT obstruction. One factor is the mitral valvular factor. If you have a large anterior leaflet and with redundant tissue, you can also have an anterior displacement of the leaflet coaptation points. That can be because you have different length ratio of the anterior and posterior valve leaflets, or the posterior leaflet length, the coaptation points, or the anterior displacement of the papillary muscle. Also, an inappropriately sized mitral annuloplasty ring can cause SAM. There are physiologic conditions like hyperadrenergic states, decreased preload or decreased afterload. Clinical conditions such as hypertrophic cardiomyopathy, post-mitral valve repair surgery, post-aortic valve replacement surgery, the Buterman stress test, hypertensive heart disease, acute MI, pheochromocytoma, or diabetes can all lead to SAM. And also ventricular factors, which is anatomical, having a thicker septum over 15 millimeters, an aortomitral angle less than 120 degrees, and hyperdynamic left ventricle, or small LV internal diameter during systolic can all lead to SAM. When we look into the pathophysiology, how systolic intermotion of the mitral valve can lead to cardiac arrest, first what we see is hypotension because there's limited outflow. Then we try to give volume to compensate the hypovolemia, and we give inotropic agent to increase the blood pressure. This will lead to a high CVP and a low cardiac output because it's causing further obstruction of the outflow tract. Now, since we have a high CVP, we will give Lasix, and we try to give more inotropic agent to increase our cardiac output. This will lead to more LVOT obstruction and ultimately into a cardiac arrest. When we look into the echo-guided therapy of SAM, the first thing is to diagnose LVOT obstruction. This is the most critical part. The first thing then, we will avoid inotropic agents. The second, we're going to use low doses of beta blockers. The third thing, we're going to increase preload by volume expansion. And fourth, we're going to increase afterload by norepi or phenylephrine. So the key points are that early diagnosis of SAM is important, that PA catheter waveform analysis is probably the very first visible sign of significant mitral regurgitation, and you can identify it based on the V wave. The utilization of a TE to confirm SAM and differentiate from any other pathology is important, and then based on the diagnosis, goal-directed treatment will improve patient outcome. Thank you.